Welcome everyone to our first clinical lunch and learn of the new year. Today's topic is an introduction to cognitive behavior therapy with children and families. But before I introduce our presenter, I'd like to go over a few things that is important to know about the webinar. I think many of you have signed on to listen through audio broadcasts, so I just want to make sure that you understand that in order to hear, then you'll have to be using your computer speakers. If you want to listen through the phone or if you don't have computer speakers, then we need you to join the teleconference, and you can go up to your menu where it says Communicate, click on Join Teleconference, and then call in using the call-in number and code. If you're already joined in through the teleconference, then you're fine, and then you'll be hearing through the phone system, not through your computer speakers. Currently, all participants are muted. We will hold a Q&A period at the end of the webinar where you can ask questions of the presenter. You can submit questions through the chat box throughout the webinar as well to be answered at the end. We just ask that when you ever submit a question through the webinar, make sure that you click Send to all panelists for us to be able to see your question or comment. At the end of the webinar, there will be a feedback survey which we ask that you complete so that we can continue to improve our webinar experience. The webinar recording and slides will be posted on our ctacny.com website. So let's get started. We're very happy to have today's presenter, Alyssa Gleeker from the Center for Mental Health Implementation and Dissemination Science for Children, Adolescents, and Families at New York University Child Study Center. She'll provide a basic overview for us of CBT with a focus on a couple common techniques, particularly to working with children. Welcome, Alyssa.
Hi, everyone. I'm happy to be here today talking about cognitive behavioral therapy with children and families. So I thought that we could start off a little bit by just talking about what the empirical basis for the model and techniques of CBT are. So I think with the training initiatives that have gone forth within New York State and individually at a lot of clinics, we all know about empirically supported treatments. And CBT has been studied through a lot of research across a number of different disorders, so trauma-focused cognitive behavior therapy or trauma work, depression, anxiety, oppositional defiance, and across the age span of children. And it's been compared to other therapies, and in many cases across a number of these disorders, it's been found to be more beneficial than other types of treatments for certain disorders. So I really want to start out this discussion with focusing on using empirically supported treatments, which aren't always cognitive behavior therapy, but using the research base as our guide to make decisions about treatment. And it just so happens that a lot of those treatments do fall under the guise of cognitive behavior therapy. So what does cognitive behavior therapy mean? We're going to break it down into three different parts. So the first part is our cognitions, the thoughts and the patterns of thinking that we all have. And whether we're kids or adults, we all have different patterns of thoughts that we tend to have in different situations. So if we're more anxious, we may tend to see the world in a way that confirms our underlying thoughts that maybe people don't like us. So if I walk past a group of people at a mall and the two people are talking to each other and kind of laughing, if I have a tendency to view the world in an anxious way, I might think they're laughing at me. And my behavioral response, which is the second box here, may be to feel embarrassed and want to leave the mall or leave the mall right away. The therapeutic part of this, or the treatment part, will be the interventions, and some of those we'll talk about today, and hopefully we'll have the opportunity to talk about more of those after. We could go through this with an oppositional, so taking the same type of situation where the situation is I walk by two people at the mall and they're laughing, I may think, oh my goodness, they're laughing at me. But if I have a tendency towards oppositional behaviors, my thought might be, my behavioral response to my thought may be very different in that I think, how dare they laugh at me? I'm going to teach them a lesson, and I follow them or I go after them. So what is CBT? Well, it's a type of therapeutic intervention. It's also broader than just the intervention techniques, because cognitive behavior therapy is a model of how to view children's problems. And not just children's problems, that CBT has been found to be effective in many adult problems as well. But it provides you a model of how to view the problems. It also, in terms of the intervention or treatment part, provides us with a specific structure for sessions. And we'll talk more about that, but it's going to provide us with an agenda for that, which is most always going to start out with checking in, setting an agenda, reviewing the practice. And it's a specific set of therapeutic techniques. So it's a set of techniques that, when applied together in a specific order and structure, have been effective in treating many different problems. Some more about the basics of CBT, and I kind of went through something like this, but in this, the CBT model with the cognition, emotion, and behavior linked together, we're going to think about a situation where maybe the teacher at school tells a child that their problem was wrong. And some kids might be able to brush that off and think, well, without practicing, you never learn anything. But other kids might have a tendency to think along a different pattern. So maybe they have a core belief about being stupid, or that they're useless, they never do anything good. Or maybe they have a failure-oriented cognition. No matter how hard I try, it's no use. And CBT is going to conceptualize that these cognitions link or elicit, they bring about different emotions within kids. So maybe the first set of emotions is the child feels sad or disappointed, and their behavior from that may be withdrawn, or they become sad or tearful. And in the second direction under emotion, maybe they tend to get very angry, very frustrated, and their behavior patterns tend towards the externalizing, where they throw something or they become aggressive. So I think it's important to note that in this conceptualization of problems, the thoughts are very important, but the interpretation and the link between that thought and your emotion and how that links to your behavior is very important in terms of deciding what treatment interventions you would need to do with that child or that family. So I want to take a minute and think about conceptualizing cases with CBT. So these are some questions to ask yourself when you're looking at a case. Let's say you have a case who's presenting with disruptive behaviors in school. We're going to think about our first question. What factors are maintaining the child's behavior? What I'm thinking are there family factors that influence the child's behavior, for better or for worse? Are there peer factors? Does my client goof off in class, and that's the bulk of how they get peer attention? I worked with a client recently who it was like a Pee Wee Herman-ish voice, and it was very goofy and different. But what was maintaining his use of that voice was it got him a lot of attention from peers. And this was one of the only ways that he was getting attention from his peers. And are there things that are going on at school? Is there poor academic performance? Is there a conflict with the teacher that are also influencing that child's behavior? We always want to take time to think about the child's strengths and weaknesses in coping. That's going to really allow us to leverage strengths of the youth and of their family. So if we're thinking about this more broadly, family strengths are very important too. And then the weaknesses in the coping become areas that we can target for intervention. So I'm hoping that through this discussion, you guys are able to see how we're starting to build a whole conceptualization of this case from this cognitive behavioral perspective. I think I mentioned these three factors. So we want to look at factors that maintain the problem and also what role they have in influencing those. So I had listed up here peers, parents, school. Also the labeling of problematic thoughts. We want to start very early making hypotheses about what the child is thinking. Are they feeling like they're no good? Are they feeling like no one loves them? Are they feeling like no matter how hard they try, they're not successful? Because we will intervene on those thoughts. A lot of the time with children, it can be very difficult for them to label their thoughts. So I'm sure that all of you have had the experience with a client where you've asked them, what were you thinking at that time? And I'm sure you've gotten the response that I have a million times, and I wish I had $1 for every time I have gotten the response, I don't know. But what children are much better at most of the time labeling is how they felt, what their feeling was. So oftentimes we'll use that, how did you feel in that situation? Maybe the child responds, I felt sad. And you say, what was the thought that was making you feel sad? Another helpful thing too is I like to call them hip pocket patients. So a patient example that I keep in my hip pocket to pull out, and surprisingly this client is going to have a lot in common with my current client and have similar patterns of thoughts, so that I can also use that as one time I worked with a client who told me they might have felt like this or like that or this other thing, and then give the child some directions to either say, oh, I felt those things before, or no, mine is different. We're also going to be working very early on to identify problematic behaviors, the behaviors that are causing the child issues with functioning. We're going to use the strengths to increase those positive behaviors, those behaviors that are adaptive for the child and bringing about positive responses for their environment. And we're going to try to teach them appropriate behaviors for coping and ways to replace these other behaviors that are not helping them do the things that they need to do. So I think that I've kind of given some directions within this, but we're kind of going to conceptualize these problems within two classes, two broad classes. The internalizing problems, which would be anxiety, depression, shyness, and those disorders within there, and externalizing problems, which are impulsive problems, aggressive problems, oppositionality, or conduct problems. We're still going to focus on those three parts of the problem: cognition, emotion, behaviors, and how these come together to either facilitate or not facilitate the child's overall functioning. But the interventions are going to be different based on what class these children load on. This is just another way to conceptualize this internalizing and externalizing dimension. For kids with externalizing problems, the aggression, overly frustrated in some ways, what we would more commonly term acting out behaviors, we can conceptualize that they're in some ways under controlling their behavior. They get frustrated, they can't cope with it, they throw something across the classroom. Versus internalizing dimensions of behavior, which are more over-controlled. If I am anxious in a situation around my peers in class, instead of doing these under-controlled behaviors, maybe I just stop talking completely. So I'm controlling my talking. I'm over-controlling my behaviors. And I broke these out just one more time so that we can really kind of focus on these two dimensions. So this is an example of a case where he's oppositional, he's acting out in school, he's getting in trouble for speaking out of turn at school, for being out of his seat, and for throwing things. And this was a case that I treated, his thoughts were, I can never do anything right, I'm a failure, I'm dumb, I hate school, I don't want to do this, and so he gave up trying to control any of his behaviors. He was frustrated, he felt hopeless, and he was very angry. And in terms of physiological reactions to these thoughts and these feelings, he was experiencing a lot of muscle tension and physiological arousal. So his heart would beat fast, his breathing would accelerate. And when he felt those sensations, he would yell, act aggressively, and defy authority. Versus another case, this was another case, but she was an anxious girl who had symptoms of panic. She was an adolescent. Her thoughts were, I don't want to have a panic attack. If I have a panic attack at school, no one will help me. Other kids might laugh at me. I'm going to die. No one can, she was school refusing, so no one can make me go to school, and no one understands what I'm going through. She was anxious. She felt panicked. She worried all the time. She also had high physiological hyperarousal with shaking, sweating, increased heart rate, butterflies in her stomach. And what she did, which is what maintains anxiety, is avoidance. And what Chantel was doing was avoiding school and most other locations outside of her home. I also had another case who described this same avoidance as, I feel like nothing bad can happen to me when I'm laying on the floor of my basement. So at this point, I'd like it if anyone who has a case that you think we can conceptualize from this thought, emotion, physical reaction, and behavioral standpoint could write in a case in the chat box.
So we'll just take a couple seconds to allow you to think of a case that you would like help conceptualizing in this way. Just use the chat box function that's on the panel on the right, and then make sure you send to all panelists. And we'll see if anybody would like to submit one example, a brief example. And if not, we'll use some of our own examples.
All right.
A couple more seconds. Okay.
Okay.
8-year-old boy who witnessed domestic violence between mom and dad.
Okay. So we have an example, an 8-year-old boy who witnessed domestic violence between mom and dad. Whoever gave that response, can you tell us a little bit about what his behaviors were and any thoughts you might think he was having? The 8-year-old boy who witnessed domestic violence. He gets very aggressive towards mom when he's angry. So from a behavioral standpoint, I think one of the things that this child is probably reenacting is these behaviors were modeled for him, and now he's repeating that pattern of behavior. So I've worked extensively with a lot of kids with trauma and witnessing domestic violence. So I'm going to add in some of the details that I think might be there. So in terms of, I think we have some information, and I'm going to scroll back to Michael's example as I go through this. I think probably some of his thoughts, well, let's get to his thoughts in a second, but emotions, I think he feels angry, and he feels probably frustrated, and I would say confused, if we could use confused as an emotion. And I think he's clearly having that physiological hyperarousal. So when he's angry, he's making threats to kill mom. He's aggressive at school or at home. He's feeling those increased physiological sensations and tension within his body. And this is leading him to yell, act aggressively, defy authority, and cope with those feelings in a way that has been modeled for him by his father in this pattern of domestic violence that he's witnessed. I also have in here that he hits mom when he gets angry. So not only does he yell and do those things, but he actually is physically violent. In terms of the thoughts, I'm not exactly sure from the, so I have a little more information. So the thoughts, I think, center around confusion and probably his place within this, which is probably something, how do I hate dad and love dad and have watched him do these things to mom, and it doesn't make sense to me. And I think possibly he's questioning some of these aspects of this relationship with his father and his mother and how this factors into the love for him. Not totally sure if that's accurate, but we would spend some time exploring that if we had more time to do it. I'm going to move on for a minute, and at the end, if we have more questions about that case, we'll come back to it. So some of the hallmarks of CBT that distinguishes it from other types of therapy are its focus on setting an agenda within the session. And this helps to keep us on track and really focus on the client and their families getting the different skills that we want to teach them and impart to them. And I think one of the misconceptions about cognitive behavior therapy that are out there is it takes a cookbook or cookie-cutter approach to that. And that's actually very untrue, and I'd like to speak more, but in the spirit of time, I'm just going to kind of give you my answer for this is we're going to make sure that we individualize things. So let's say today I really want to focus on Chantel's ability to cope with different feelings. And so yes, I have an idea in my mind about what I want to focus on in the session, but what I'm going to do in this beginning of the session with her while we're focusing on the agenda setting is find out what was going on in her life during the week and see if there's any way to link in the issues that she's bringing to me in session with the material I want to. And I would say that in my experience, a good 98% of the time, there's an overlap between what the child or the client is coming with and wanting to talk about and what I would like to talk about too. And there's a way to link them both up so that the client is feeling heard and feeling like their issues are being addressed. And I know that I'm giving them skills and imparting skills to them that they can use and generalize through the week so that we decrease the chance that those things are going to happen again for them. It's an active approach to treatment versus a passive approach. So most of the time in session, I am teaching them or working on coping skills, or I'm working on exposure to anxiety in Chantel's case, or I'm working on exploring what thoughts are going on for Michael. So there is an active component of treatment. I don't like the word homework. I was at a training myself where they told me they were going to assign me homework, and as a grown adult, the thought in my head was, no way, I don't do homework anymore. So I usually use the word practice, and this is coming from someone who did fairly well in school for a long, long time. I can only imagine when we use the word homework for a lot of our kids who aren't doing well in school. It has such a negative connotation. So although it says homework, and you might hear about that in a lot of the other techniques you know, I usually call it practice and find that just that difference in terminology can really increase their ability to follow through on what I'm asking. And CBT uses a Socratic style. What I mean by that is we're going to ask questions and have conversations that help lead the client to their own decisions of thinking. We're going to use data and feedback. We're going to take ratings or use assessment measures over time that help us know whether or not the client is getting better or not. and it's present focused. So it's not that CBT doesn't think the past is important. So clearly this example that we just went through with the 8-year-old suggests we need to address the past, but we need to address the past into the extent that it impacts the present and the future for the child and family. I'm going to say a brief bit before we get into these specific components that we were going to talk about today about what a components approach to CBT is. So a component is, I think we've probably all been through a lot of different trainings where we've learned different approaches to treat different types of disorders. And within a lot of them, let's take problem solving, is in a good number of these different protocols. So when I talk about components approach to CBT, it is these different interventions or modules, if you will, that have been shown to work across different disorders. So why am I suggesting a components approach to CBT? Well, components have no fixed length. We can do them with a little bit more of an idiosyncratic timeline. We're going to maintain that session structure that we do with CBT, and we can thread together multiple components to come up with a highly effective treatment for a particular individual that's more tailored to that individual client. And we're going to make sure that we're using the evidence base to make decisions about treatment. So why do a components-based approach? My first point would be who has time to learn the 400-plus manuals that are out there for all the different disorders. It's not a feasible target for us. I mentioned this before, lots of the manuals use the same technique but presented in slightly different ways, and problem solving. So I've learned a bunch of different evidence-based manuals before, and a lot of them have problem solving in it. PCIT has problem solving, depression treatments have problem solving, a lot of anger management protocols have problem solving. And the big thing that differs between them is the acronym that they use to teach the steps of problem solving. So my point with a components-based approach to CBT is if you've learned problem solving as part of PCIT and you're comfortable with that, if you have a child who's anxious or depressed and needs problem solving, those problem-solving steps, that acronym is still effective, and it makes sense that you could use it. I want to take a step back and talk a little bit about parents in the treatment process. Parents are integral in the treatment process, especially with children, and it tends to be the formula is the younger the child, the more important that the parent becomes in the treatment process. They're also very important not just with internalizing problems, but there's specific treatments for acting out behaviors that really the parent is the focus of the intervention, not that the parent caused that problem, but their response to some of these behaviors is going to be integral and the catalyst for change. We need to identify potential parent role in the cycle of interactions, both positive and negative, examine the maintaining variables, work with them on contingency management, engage the parent in the treatment process. And one of the things that I really want to make the point in this slide and in the next is that the parent is such an important part. They are the expert on their child, and that 45 minutes to an hour a week or every other week or once a month that you spend with them pales in comparison to the time that the parent is typically spending with the child. So it becomes such an important ingredient to success that the parent is involved in treatment. They are the expert on their own child, and treatment without them very often becomes less effective. So we have to fight that dry cleaner model of therapy where very early on where the parent thinks that they may drop off their child and come back, or that the child thinks that their parent is not going to be involved. We really need to engage everyone in the process. So the parent is involved in multiple levels of this process. They're involved as the consultant. They provide information about the behaviors in their child. They're the cheerleader. They provide encouragement for their child. They're a coach. Very often they're going to help their child work through the skills that you've taught in therapy outside of therapy. And they're the client. They're the target of certain aspects of intervention. So here I've just put up some different components of cognitive behavior therapy work. So there's psychoeducation. For those of you who've been through trauma training, you know that we do psychoeducation on trauma. For those who have been through protocols on externalizing disorders, you usually start with psychoeducation on externalizing problems. So that's a very common approach. There's somatic management. How do you deal with the different feelings? There's coping, cognitive restructuring, timeout procedures, which is a parent intervention, contingency contracts, which is a parent and child intervention, practice, problem solving, instructional aspects, shaping different behaviors using strengths and using that behavior that's a strength to build it, modeling and guided participation. We're going to use role plays very often in session to increase the likelihood that they'll engage in the behavior we're teaching outside of session. And that would fall under skill training and rehearsal. The more we rehearse a different behavior, the more likely we're to do it in real life. So I want to talk about problem solving as one of our first things. And the first thing I kind of want to pose as a question is, my guess is that most of you have done some sort of problem solving with children or with families as part of your practice. Now I want you to think about, how do you do it? In the last training like this that I did, when we went through an example of how people typically did problem solving, it differed in some key ways from how we're going to go through it next. In other aspects, there were folks who had done problem solving and learned a specific technique and did it very much in the way that would be suggested by the evidence base. My guess is that most of you have had exposure to problem solving as part of a lot of the protocols that you've learned. What I'm going to use for the acronym is, I like the acronym STEPS to problem solving. It just seems to make sense to me. I've worked with some other protocols that had acronyms that were less intuitive, I think. So the S is going to stand for identifying and stating the problem. So very clearly stating the problem that's at hand. So oftentimes one of the things that folks do when they have a problem is it's scary to even think about what it is. So we want to get them to stop procrastinating and building the anxiety around the problem or the difficulty in solving it by identifying what the problem is. Thinking of as many different solutions to the problem that they can. E is for evaluating the solutions, and P is for picking the best one, and S stands for see how it works. So I want you guys to think of a problem. Does anyone have a problem faced by one of their clients that they've either used problem solving on or that they're thinking about using problem solving on? And please use the chat box to submit a problem.
Just a reminder to use the chat box and make sure you click send to all participants. Again, we're asking if there's a specific problem that we can work through using the STEPS model as an example. Please type that in now. If not, we'll move ahead with one of our own problems.
All right, not wanting to get dressed in the morning for school. We're going to take this not wanting to get dressed in the morning for school. So that would be the S part of it, right? The stating the problem. I don't want to get dressed for school in the morning. Let's go back here. So what are possible solutions? And please use the chat box to contribute any solutions that you can think of. I can think of one solution, which is not getting dressed in the morning, right? Okay, that's a good one. Getting clothes out the night before. I can think of getting dressed in the morning as a solution, right? I can think of another solution, getting the clothes out the night before, and instead of maybe part of the problem is the parent and the child start arguing about this getting dressed thing, so maybe one of our solutions is to list the steps on a piece of paper that the child can follow to decrease the negative interaction. Giving the child 2 choices might be another solution. So in terms of this, I'm going to skip to the next step in interest of time, but you can see how we can keep going. And the reason we generate multiple solutions to the problem is so that we can think of the pros and cons to each, because sometimes a solution comes in an unlikely thought. So in terms of evaluating the solutions, I have a few different thoughts. We would go through the pros and cons of not getting dressed in the morning. And I think probably the biggest downside is, my guess is, it's a negative escalating cycle where the parent is getting more angry. It feels really bad for everyone. The kid's late to school, mom's in trouble at work, whatever it is. So that's one. I think one of the things that I really liked was the idea about laying the clothes out the night before and giving the child a choice. And the other thing I would say in terms of solutions would be another thing that we're going to talk about in a few minutes, which would be adding the addition of a reward for successfully doing this. So I think there's multiple ways we could go with that. So I'd say in terms of picking the best solution in the interest of time, I think one of the best solutions is going to be doing some of the prep work the night before and adding the addition of a reward for successfully completing the steps to getting dressed and in the car in the morning. And then we're going to see how it works and take some data on it for a week. Another behavioral intervention for slightly older kids is a written agreement for preventing and solving problems. So behavioral contracting, we're going to do some of the similar steps to problem solving. We're going to state the problem, identify different solutions, and come up with a contract between the different parties on what's clearly expected in terms of behaviors. And we want to avoid confusion. This is a collaborative interaction with the parent, child, teacher, and therapist, whoever is involved in this. And it's not one-sided. It's really good for adolescents who are very triggered often by feeling like other people are making decisions for them. So this is an example of a potential child-teacher behavior contract. I agree to be in my seat by 8:30 a.m., raise my hand before I speak, complete morning assignments before lunch recess, and complete afternoon work before the final recess. Now, most of you may be thinking, or I think when I read this, is I'm sure this child has other issues that are not going extremely well for them, but we have to start somewhere in terms of shaping behavior. And in this case, we picked these 4 things. And it says, I agree that if I do the above, I will earn extra time in the art room, extra time at the computer station, or this is an older example, points that I can trade for Pokemon cards. I agree that if I do not do these each day, I will not be able to participate in recess activities. So one of the things, and there's another lesson in this, is this was an example of things for people to troubleshoot and problem solve. So one of the things that I would say is we would need to work on, if this was our behavioral contract, if I was earning points that I could trade in for anything, privileges at home or privileges at school, I would want to delineate how many points I could earn for those behaviors. The other thing I would say about this contract is I I would build in a buffer zone so that if the child does 3 of those 4 things, they could still have the possibility, or even 50% if they're not meeting any of those things right now. We want to set them up for success and set the teacher up for success in terms of structuring it so that even if the child's not perfect, they still get a reward. So now I'm going to talk about some different attending strategies, and these are mostly parent or teacher interventions. And so one of the things that I wanted to stress in these components that I selected was how important and how integral parents are to this treatment process. So the specific strategies we're going to talk about are attends, praise, and active or selective ignoring. So what is an attends? It's actually it's a form of praise. But what we do with an attends is we verbally describe positive behaviors so that we're giving the child information about what the appropriate behavior is and what kinds of things bring about a positive response for their environment. One of the things you have to make sure of with attending is that we're not being kind of saccharine about it or being over the top about what we're recognizing. The purpose of it is to provide external monitoring to increase internal monitoring, that the child picks up the skills to monitor their own behavior internally by hearing your external monitoring. Provides the child with information about appropriate behavior. So very often in that cycle of negative attention that can build with kids is that they've learned that the quickest way to get attention is through negative behaviors. And this becomes part of reversing that pattern of interaction. So the action is the consistent description of appropriate behavior that's observed. So I'm sure this rings true with everyone here. I could say, if I could see you, it's so nice that everyone is sitting here listening so attentively and taking notes on this webinar. If you could see me, there's a hint of sarcasm, but not tons, because I'm sure all of you are doing that. And attends is slightly different than praise, but let's talk about praise for a second. It's positive reinforcement of a particular behavior indicating the parent's approval or satisfaction. It's external reinforcement that can lead, again, to increased intrinsic motivation to perform specific behaviors, and it provides information on appropriate behaviors. So this is verbal or nonverbal positive reinforcement, and, you know, it could be a thumbs up, it could be a high five, it could be a hug, or it could be, wow, you're doing a great job. But you can see how it differs from an attending type of model where we're not giving as much information about the specific behaviors that they're doing great with. So what is, this is another tricky one. This is active or selective ignoring. I like to call it, I kind of like the more positive spin on this name where I like to call it selective attending, so that there's certain behaviors that I am going to withdraw my attention for, but there's other ones, it's an active intervention in that other more positive things will get attention during this time. So what it is briefly removing all attention from a particular negative behavior, and it's effective for attention-seeking behaviors. So these are, you know, a kid who screams loudly at their parents at the grocery store. They're doing that behavior to bring attention to them and their parent in order to meet whatever goal they want. And attention is given for appropriate behaviors. The purpose is to diminish the behavior and not reward it with attention, and this is strictly based on the principles of reinforcement. So what you do is you withdraw eye contact, verbal responses, and nonverbal responses to the behavior that you're trying to ignore. So an example, I'll go with my example of there's a child, the parent is pushing them through the grocery store, and they are screeching at the top of their lungs in order to get attention or candy from the parent. The quickest way, even though it is very difficult, is to remove attention for that behavior. Because there's certain behaviors like those high-pitched screams that really the only intent of those is to get attention. So what active ignoring or selective attending works well for is whining and fussing, pouting and sulking, loud crying or tantrums that are intended to punish others, and loud complaining or continuous demands. What it doesn't work well for are behaviors that can injure other people or property. So the guidelines for selective attending or active ignoring are briefly removing attention from the child, refusing to argue, scold, or talk or get into that verbal discourse, turning your head to avoid eye contact, removing signs, your nonverbal communication of anger or amusement at gestures, or pretending to be absorbed in another activity, and be sure that the behavior does not result in an unintentional reward by you. And give the child lots of attention and make sure that they can get your attention when they stop doing the behavior or when they would typically engage in the behavior and they don't do it. And that's how we're going to shape it over time. I'm going to pause for a minute, and is this when we open it up to questions? Okay. All right, so those were the things. I guess I would like to say, and I don't have a slide on it, but I'm happy to provide one for them to put on the website, that one of the primary cognitive techniques that we would do in order to get through the thoughts is going back to those earlier slides. So this is a cognitive technique to get to thoughts. We would use emotion. How were you feeling, or what were you thinking when you felt so angry? And let's say the child is, I was thinking that I was going to hurt someone. And you say, well, what was making you feel like you wanted to hurt someone? And let's say they said that those people I walked by were laughing at me. And then I would continue to ask the same question, and I would tell the child this so they don't get super annoyed at me for asking the same question over and over again. But what was bad about those people possibly laughing at you? Well, they thought that they didn't take me seriously. What would be bad about that? That they thought I was stupid. What would be bad about someone thinking you were stupid? That they thought I was no good. And maybe that's the level of thought that I want to intervene on with this child. But I'm using that to demonstrate that there's ways to get to a deeper level of thought with children or adolescents especially. Should we do some of these?
So let me just, we're going to move on to our Q&A period. Thank you so much, Alyssa. I just wanted to remind everybody that the webinar recording as well as the slides will be posted on our www.ctechny.com website. Now, if everyone can take a few minutes to and we will have some few minutes to respond to any questions that you have. Again, you can use the chat box. Make sure you send to all panelists so that we make sure we get your question. And as you're submitting those, I did want to ask Alyssa to see if she could, there was another case example when we asked people after we did the Michael and Chantel case, wondering if you could process one of those as well as people are writing in their questions. So one case was submitted around school refusal, and they had outlined that the emotions seemed to be the fearful, nervous, or angry, that the sort of physical reaction was hiding under covers and ignoring mom, or mom trying to get her out of bed, and then crying, refusing to go to school, staying in bed. So how could we conceptualize that case using the CBT framework?
Okay. So using the thoughts, I'm not sure exactly what her thought is surrounding going to school or what's bad about that. There's very often different reasons why. So from an anxiety standpoint, and it looks like I see under the emotions that there's nervous and angry going on here, which is very common, especially with school refusal or anxiety in general, that our kids learn that whereas just crying or saying I'm scared used to get me out of a situation. Now my parent isn't giving in on that, and they escalate to anger, and sometimes the anger lifts the demand of having to go to school or having to do X activity that makes you nervous. So very often with anxiety cases, you can see them cross over into angry behaviors sometimes. In terms of thoughts, I'm not sure if this is coming from a not wanting to be away from your parent kind of place, a separation anxiety type of place. So something bad might happen to me if I'm away from mom. Or is it coming from Chantel? The example we had earlier was also a school refuser. But she was worried she wouldn't be able to get help for those panic symptoms and something was going to happen to her physically if she went to school. Other kids may be afraid of social situations, having to interact with peers or other adults in their environment. So I'd want to get some more information about that. In terms of developing, let's say this is an anxiety type case, one of the things that we didn't talk about, if we're using these components type approach to CBT, is I would devise a program that had some particular components with psychoeducation about what anxiety is, building a fear ladder or fear hierarchy with graduated exposure to whatever thing is making this child scared or nervous, whether it's social interactions, whether it's the school environment, whether it's panic. I would devise exposure, and then I would probably have to put in place a reward system for school refusal. And then let's say all that goes really well, we would do maintenance and relapse prevention.
Thank you, Alyssa. I think we have a couple questions that came in, and I think we're going to try to answer those now in our Q&A period. So we have one that says, what do you recommend for parents who continue to report the same behaviors despite teaching new skills each week?
That's a great question. So feel free to email me if you have a great answer to that as well. But I'll also tell you some of the things that I've found very helpful. This is an active treatment process. So I would try to re-engage the parents in that process, and I do a lot of problem solving around. So I'm making an assumption here, and maybe it's an incorrect assumption. So, but we don't have the ability to talk back and forth. So if it's an incorrect assumption, forgive me. But I'm assuming that one of the things that's going on is the things that we talk about in session aren't being implemented as fully as I would hope they would be in the home. So what I would try to do is some really good problem solving around what the barriers to doing those things in the home are in order to solve some of those problems to increase their ability to use these skills, whether it's a parent skill or whether it's a child skill. I think that that problem solving is going to go really far in terms of helping to solve the problem and getting a different system in place at home. The other thing that I would do is, I think, I forget on what slide, but we talked about measuring data. So the other thing, if it's not this issue of things aren't changing, so why would we expect behavior to change, and we have to figure out a way to get different things in place, maybe it's an issue of the change has been gradual, and although things have changed, the parent doesn't see it since the change process has been gradual, and that's one of the reasons why I think measurement of progress on my key intervention variables over time is very important. For example, if I want to increase school attendance, I would be tracking the number of days each week the child attends school so that maybe the parent, we had a step back and the child missed school for 2 days in a row, and the parent says nothing ever changes, I could go back to my graph and say, hey, look, I know it feels that way sometimes, but we went from missing every day of school to missing 2 days of school within the last 3 weeks.
Great, thank you. We have another question from another participant that says how to do this with young children. For example, can you incorporate this into play therapy?
Yes, I think one of the things about a components-based approach to CBT and to what we're doing is that it can be incorporated with a lot of your different skills that you're already using. So one of the examples, I had a client one time that was a young child. I believe they were 4 at the time, and he was selectively mute, and he wouldn't say anything to me. But if I used a puppet, in the beginning, he would talk to the puppet. The puppet would, through me, feed the information back to me. I'd tell the puppet, and the puppet would tell the child. And so through that, we were able to lay the foundations of work and eventually fade the puppet so that we were doing that. I think another thing that I want to point out is with younger children, the parents become increasingly more important to the interventions too. Another child had a really hard time engaging in treatment but really loved trains. So we would talk about different techniques. We'd practice them with dolls and then practice them together. And then at the end, we would take construction paper and make a train car out of construction paper with notes on what we'd learned there. So at the end of treatment, we called it his CBT train that he got to take home and put in his room.
That's a wonderful example. I think we have one more question, and that is, do you have any resources you recommend for visual tools to use as supplement to the wonderful tools you already presented, for example, like a feeling thermometer?
And
if you have any, then we can also post them on our website as a resource.
I have some, and I'm happy for you guys to post them through CTAC, or if you ever want to contact me, that's fine too, and I'm happy to provide those.
And this is Alyssa's contact information. And again, you'll have the recording and the slides on our ctacny.com website. So thank you very much, Alyssa, for a wonderful presentation, a great introduction and overview to CBT. Again, if anybody has any questions or concerns, you're welcome to email us, and I'll put our contact information here as well, lydia.frank@mountsinai.org, with any questions or comments around the webinar. And again, you can check out the website at ctacny.com. I just wanted to point out that we have 2 more upcoming webinars. The next one's January 16th at 12, What's Your Compassion Index? Understanding Our Tolerance to Secondary Traumatic Stress and Compassion Fatigue by Cheryl Sharp. And then on February 13th at 12 also, Engaging Children and Caregivers into Services, presented by Dr. Mary McKay. Thank you, everyone. I think our time is about up. Thank you, everyone, for your participation. A quick reminder that as you log out of the webinar, you will get a feedback survey that will pop up on your computer. It's very important for us that we get your feedback so we can continue to improve these webinars. Please complete that survey. As many as we get back, the more information we have in order to make these webinars even better. Again, we know we received a number of questions and comments from people. Due to the amount of time, we can only talk about a few of them. However, you can continue to email us, and we'd be happy to answer any other questions after the webinar. Thank you again, and have a wonderful day.